Welcome to AETCM, the emergency medicine channel. Ma'am, shall we start?
Yes.
A 56-year-old male who presented to our ER with complaints of 3 episodes of hematemesis since today morning and melena since the past 2 days. Coming to our initial 10-second assessment, the patient was conscious, oriented and obeying commands. Coming to primary survey, airway appears to be patent, patient speaks one full sentence, no pooling of secretions, oral cavity was clear, no active hematemesis was present. The angle of mouth showed mild blood stain, no hoarseness of voice, no stridor. Coming to breathing, air entry bilaterally equal, saturation of 98% in room air, respiratory rate of 21 per minute. No crepitations or wheeze was noted. Coming to circulation, all peripheral pulses were palpable. BP was 70/50. So at this point, we inserted 2 large bore IV cannulas and started the patient on IV fluids. Heart rate of 100
What fluid was selected?
Ma'am, normal saline was started.
Okay. How much did you bolus?
2 pints were bolused.
Okay. Approximately 1 liter. Okay.
Heart rate of 120, capillary refill time of more than 3 seconds. And at this point, to a large IV bore cannula was inserted and IV fluids NS was bolused. Coming to disability, the GCS was 15/15, pupils bilateral equally reacting to light. Coming to exposure wise, the GRBS was 120 and temperature was 98.6 degree Fahrenheit. Coming to adjuncts of primary survey, ABG was taken showing a pH of 7.224, PCO2 of 35 and bicarb of 12, lactate of around 10, indicating there is metabolic acidosis, HB of 6.2. So we arranged 2-pint PRBC. INR was also sent and it was came to be 3. So FFP was also arranged and immediately transfused. Emergency blood grouping and cross matching was done. Blood and blood products were arranged and continuous cardiac monitoring was also done.
So this patient came with upper J bleed and he is in hypertension, tachycardia is there, and ABG is showing severe lactic acidosis. So he is in hemorrhagic shock. Right. So what is the class of hemorrhagic shock in this patient? So how many classes are there hemorrhagic shock?
4 classes was there hemorrhagic shock.
Okay. What is first class? So basically 4 classes are there. In first class, the patient's blood loss will be less than 15%. Second class, it will be 15 to 30%. Third class, more than 30%, and fourth class, more than 40%. In first class, all the parameters will be normal, like respiratory rate, BP, pulse pressure, urine output, everything will be normal, and GCS also will be normal. In second class, patient will be having tachycardia and reduced pulse pressure. Okay. And in the third class, patient will be having tachycardia will be there, reduced pulse pressure will be there, and systolic BP drop also will be there. So this patient is in already the initial BP was 70/50. So patient might be in class 3. And in class 4, all these things will be there. Along with that, patient will be a little bit tachypnic. There will be low sensorium, reduced urine output and all. So all these classes we can also differentiate based on the base deficit also. So class 1 base deficit will be less than -2. Class 2 it will be -2 to -6. Then class 3 it will be -6 to -10. And if it is class 4 it will be less than -10 base deficit will be there. So in this patient it will be either class 3 or class 4. So in class 3 or class 4 we should arrange for just blood group and cross match or something else.
We can also plan for INOT.
We should plan for massive transfusion protocol. Okay.
Coming to secondary survey sample history, 56-year-old male who is a known case of CLD with
What is massive transfusion protocol mean?
Ma'am, for the 24-hour period, we are transfusing at least 6 pint PRBC FFP.
More than 10 in 24 hours or more than 4 units if required in first hour.
Sample history, 56-year-old male who is a known case of CLD with portal hypertension, type 2 diabetes, who consumes alcohol in significant amount, presented with 3 episodes of hematemesis, fresh blood, approximately around 2 liters. The last alcohol intake was 2 days back. Past history of hematemesis 6 months back, for which banding was done. Not on any drug history, not on any antiplatelets or NSAIDs. No history of any retching prior to hematemesis. No history of fever, abdominal distension, decreased urine output, altered sleep pattern. Malaria was present. That the bystanders give that there is blackish tarry stools since the past 2 days.
What is the significance of asking all this history?
Ma'am, the signs of precipitating factors of hepatic encephalopathy.
Hepatic encephalopathy, okay. And what is the significance of asking this history, the
Is
drug
there
history?
any other causes that point towards hematemesis? The patient is on any antiplatelets,
Warfarins,
warfarins,
NSAIDs, COX-2 inhibitors, like that. And what is the significance of asking this?
to know whether it is Mallory syndrome.
Okay, okay. Okay, so this patient, we already have a history of CLD, so the hematemesis might be because of a varicose bleed. What all are the other causes of upper GI bleed?
Ma'am, the most common cause of upper GI bleed is ulcer, peptic ulcer.
Peptic ulcer.
The other causes can be chronic gastritis, can cause Mallory's, meningitis disease, portal gastropathy, cave carcinomas.
Vascular ectasia can be there. So we should also ask for other histories, like any history of abdominal pain was there, or any chronic history of odynophagia, anything that can be because of an esophageal ulcers and all. Any history of loss of appetite, weight loss and all, that can be because of malignancy.
Coming to medication history, the patient was on metformin and glimepiride. Allergic history was nil significant. The last meal, no solid meals since the past 8 hours. Coming to systemic examination, GIT, abdomen was distended, no tenderness, bowel sounds were present. Coming to CNS examination, the GCS was 15/15, flap were present. Respiratory system, there were no normal vesicular breath sounds, no added sounds. CNS S1, S2 present, no murmurs. So final diagnosis was CLD with portal hypertension, hepatic encuff grade 2, secondary to hematemesis and malignancy.
So how did you manage this patient?
We started the patient on IV fluids. We kept the patient on NPO initially. Then we have started the patient on pantoprazole.
So initially patient is in shock. So patient was managed with IV fluid bolus. Okay, was he improving with that?
Initially, after 30 minutes, after 2-point bolus, we reassessed the BP, and this BP was still on 70/50, not improving. So we started on noradrenaline 4 ml per hour.
Along with that, what else should we give?
The FFPs and PRBCs were also transfused immediately.
Okay, so blood transfusion was started. Okay.
Then we have started on injection pantoprazole 80 mg IV stat, followed by 8 ml per hour infusion was started. We also started on
Other than pantoprazole, can we give anything else? Any other proton pump inhibitors? Esomeprazole can be given, lansoprazole can be given. Okay.
Then we have started on injection octreotide. 100 microgram IV stat was given, followed by infusion of 50 microgram per hour.
Okay. Then ideally 50 microgram stat and 50 microgram per hour infusion is only required. Okay. What is the action of octreotide?
Vasoconstriction, that decreases the bleeding.
The portal variceal constriction, it will be helping. Okay.
Then we have also given antibiotics for prophylaxis, secondary to any infections that can precipitate. SPP can precipitate hepatic encuff, and there is also hematemesis and maligna. So as a prophylactic, we also started the patient on antibiotics.
Okay. Anything else should we give?
Perinom.
What are you meaning by giving perinom?
It also as an antiemetic and prokinetic agent also.
Okay. If suppose you want to give a prokinetic agent, why are we giving a prokinetic agent?
Because constipation can further precipitate hepatic encuff. So the normal CLD patients need at least 2 to 3 episodes of normal stools to be passed. So since the patient is in hepatic encuff, not to worsen further, we also start the patient on.
And any other indication? Prokinetic agent we are giving because we might plan for an OGD-scopy. So we want to clear whatever blood or clot is there, we need to clear that also. So other than this thing, is there any other prokinetic agent which we can give? We can give erythromycin also. Erythromycin 250 mg can be given over 20 to 30 minutes. That can be given. But in elderly patients and all, that can cause prolonged QTC prolongation and arrhythmias can be there. So perinom can be given. Okay.
Then the vitals were monitored every half hourly, and we plan to keep the map of around 65 was planned. And we also plan for a rapid sequence intubation SOS. In case there is worsening of further episodes of hematemesis, we plan to intubate the patient, and consent was also taken.
Okay. So was intubation required for him?
At present, the patient is not a candidate for intubation. Patient is having a GCS of 15/15, no further episodes of hematemesis. So we just plan for rapid sequence intubation.
Suppose this patient was having active hematemesis in front of you and sensorium is low. How will you plan his intubation?
Initially, we will look at the vitals because the drug depends upon the vitals of the patient. Probably due to hemorrhagic shock and hypotension, the drug of choice can be ketamine, since it increases heart rate and also improves blood pressure.
Okay.
So injection ketamine 1 to 2 mg per kg IV stat can be given, and rocuronium of 0.9 mg per kg is given. Initial pre-medication we can use either with midas or ketamine has both the actions. Midas of
Why midazolam we are giving before ketamine? To prevent emergence phenomenon. Okay. Suppose patient is hemodynamically stable vitals, if everything is stable, what will we give?
We can go for etomidate.
Okay. So this patient is having active hematemesis and we are planning for intubation. What else should we keep in mind? Drugs we have selected. What else?
We have to bag and mask ventilation should not be too depth. We will reduce the depth of bag and masking. Don't push it too much.
Okay, what
because
will
it
happen?
Can precipitate.
Patient might vomit again and there will be aspiration again. So maximum bag and masking should be done just before giving any paralytic agent. So if we are giving ketamine as an induction agent, it might not be having much respiratory depression. So we can start ambuing only just before giving rocuronium so that the tendency to vomit will be less. Okay. What were the other blood investigation like INR?
INR was and it was came to be around 3. APTT was also on the higher side. So immediately we started the patient on.
What was the platelet value?
Platelet value was around 95,000.
Okay. Was he in DIC? You told the patient had low HB, this thing and all. Okay, so that was corrected initially. Okay. What else? What about the urea, creatinine and all?
Urea creatinine was maintained, ma'am. Urea of around 40 and creatinine of around 1.3 was.
Suppose we have a patient with upper GI bleed. How will you score the patient? Risk stratification, how will you do that?
Ma'am, there are different scoring systems. One of the scoring system is the AIM 65 score. Which predict the mortality of the patient. Each score is given one score each. A for albumin less than 3.5, I for INR more than 1.5, M for the mental status of the patient, S for systolic blood pressure less than 90, and age more than 65. A score of more than 2 indicates higher risk mortality. What
about other score?
Other score can be there is bleed criteria, there is Forster criteria, and Glasgow scale is also there.
So what is the use of that Glasgow Blatchford score? What all are the parameters?
Approximately 9 parameters are there. If none of the parameters are met, then we can send the patient on an OPD basis. Of the 9 parameters, it
If
includes
any one becomes positive, we have to plan for admission. Okay, so what are the parameters?
The parameters are HB, blood urea nitrogen, any history suggestive of syncope and melena, heart rate more than 100, any hepatic and cardiac complications.
And systolic BP. So what is the significance of urea in this?
Urea creatinine ratio is suggestive of any pre-renal renal failure.
Thing is, when patient is having upper GI bleed, right? So the blood will get absorbed from the body. So that will be going to the circulation, and that will goes into the kidney, and that can elevate the urea. So that can block the renal vessels also. That can increase the urea. So urea will be high in upper GI bleeding. So a bun creat ratio of more than 30:1 or a urea by creat ratio more than 100:1 suggests that this patient is having upper GI bleeding. So risk stratification, we are having different scores. Other than that, if we are seeing the patient initially itself in the ER, we won't be able to know the INR value, these values and all, and most of the lab parameters we might not be getting. So initially itself, if you are seeing one hemoglobin value less than 10 or systolic BP is less than 100, or if the patient is having low sensorium, such things, and depending on the grade of the CLD, we can tell that patient is having poor outcome. Okay. How is the patient now?
The patient, we have done an elective intubation was done prior to OGD scopy. OGD scopy was done and banding was done. No further episodes of hematemesis, vitals, everything is maintained.
Okay. So this patient, if suppose there is any delay in doing OGD scopy, will you place an RT for this patient? Rails tube?
No, ma'am. It can precipitate puncture the varicose bleed.
So if the patient is conscious, that itself can precipitate vomiting. Otherwise, if suppose you have intubated the patient for OGD scopy, will you place an RT?
No, ma'am. We don't place an RT.
What will happen?
Further injury can lead to further bleeding, varicose bleeding.
It can injure the varices. Then other thing is, you already told this patient one banding was done like 6 months back. So that can injure the band. And if you are suctioning from the rails tube, that again will precipitate more and more bleeding. Okay, so suppose you are in a peripheral center and you want to refer this patient to our center. And if the patient is actively having upper GI bleed, what prophylaxis will you take?
Ma'am, we will go for Singstop black mode tube and also Minnesota tube is also there.
What is the difference between the tubes?
Depends on the portals, ma'am. Both the tubes are having gastric and esophageal balloon, but in Singstop black mode tube, there is only 3 portals, but Minnesota tube is having 4 portals. So in Minnesota tube, we can aspirate both esophagus and the gastric.
Okay, it's fine. So how many varices were there for this patient?
2 varices.
Okay. Then did the BP everything improve afterwards?
Yes, ma'am. The BP improved and we gradually tapered the noradrenaline.
Okay. Thank you.